people to stop right on red. We want pedestrians to have the right-of-way of crosswalks.
With a great high wall there, tried to stop me. There was a great big sign there, said private property. But on the other side, it didn't say nothing. That sign was made for you and me. One more time, this land is yours, this land is mine. From California to the New York Line, from the Redwood Forest to the Gulfing Water, this land was made for you and me.
Now let's meet Dr. Sutherland. He is an associate professor of health administration at the University of Ottawa. He's lived in Ottawa for the past 20 years. Prior to that, he was a general practitioner in the rural areas. He worked in Alberta and Saskatchewan, and he came to Burlington at the request of Mayor Bernard Sanders and the people of the commission that the mayor has put together to look into the costs of health care and the differences in the Canadian system and the American system. And we're happy to have him here to respond to our questions and to yours as well this morning at 658-0006 or 561-7602. Dr. Sutherland, welcome. Glad to have you here.
Nice to be here.
How did you get involved in, you teach health administration. What does that mean?
That's equivalent to a great many American programs that produce the managers who look after hospitals and health centers and mental health programs and who work for governments and consulting firms and, generally speaking, are the managers of the health system.
Okay. Now, this Canadian health care system that you came to Burlington to talk about, how did it start, and when did it start, and why did it start?
That's pretty hard to answer very precisely, but it did start a long time ago.
Give me an
in the 20s and even
really,
a little bit before World War I, there were parts of Western Canada that were beginning to work together to bring physicians into rural communities, and they had a very extensive municipal doctor plan through the 20s and into the 30s when they just couldn't support them anymore and they died. But that was probably the earliest big example of a group of citizens working together rather than independently to have the kind of access to health care that they'd like to have. And that followed on through the 30s with a lot of Western Canadian governments in particular being interested in some kind of universal health insurance, and it just happened to be Saskatchewan first in 1946.
Now, what did Saskatchewan say then in 1946? What did it entail? What kind of service was made available to the people of that province?
At that time, they said they thought that hospitals were so central to health that they insured hospital services, so nobody would ever be denied access to the hospital part of care because they didn't have enough money. I think the philosophy is a little different now, but that was the beginning.
Did they buy the hospitals, the government, and operate them essentially themselves?
No, we have strictly an insurance system. In fact, that's why in health system terminology we have health insurance and not a national health system like Britain. All our hospitals are the same as they used to be. They're owned by a variety of municipalities and charitable organizations and private groups. They're all non-profit.
They're all non-profit, then. You don't have like the Humanas that we have in the United States.
No.
All not-for-profit.
Right.
Does the government involve itself, the provincial government or the national government, involve itself in any way, shape, or form in overseeing the hospitals?
Very much.
Okay.
Very much.
Tell me about that.
The hospitals all operate under strictly provincial statutes because in Canada the federal government really has a very limited role in health constitutionally. It puts a lot of money in and it exerts a lot of leverage through its money, but all the laws are written provincially, so we have a fair amount of provincial variation. But the legislation governs building, expansion, staffing patterns, quality control, reporting mechanisms, even what kinds of work a particular hospital ought to do. That's either determined regionally or provincially. At the financial level, every year the hospitals negotiate independently with the Ministry of Health and create a global budget, so that there isn't a fee for a patient who comes in. There is a negotiated sum of money which will be given to the hospital as a global budget, and the hospital operates for the year with that money.
So the hospital tells the government what it's going to cost, and then the government gives them the money. Is there any pulling and is there any? I was going to say, is there any pulling and tugging over that?
Lots.
How does it work out then?
Well, it works out that some hospitals try to overspend, and governments have been quite firm about that and have just not allowed it. So that
is there any lack? Is there any? Well, I guess what I'm asking then, is there a lack of care?
Oh, I don't think so.
Is there any threat by the hospital that if the government doesn't give us this amount of money, then so and so who needs kidney dialysis or something of that kind is going to suffer?
Yes, they make that charge all the time.
And
I suppose there is an element of truth in it, but the way that hospitals have to be looked at is really the same as all the other things that are so socially important. And if one spends at the very extravagant end of anything, whether it's roads or employment or job creation or health care, something else doesn't get enough. And the standards that have been maintained in our hospitals are really quite exceptional, and I doubt if you came whether you could find anything below the standards here, unless you were comparing us with the Mayo Clinic or something.
I listened to talk programs from Montreal about people complaining about being warehoused in halls and having to wait, hospital corridors, I guess I should say, and having to wait interminably for an operation, if it is an option operation, things of this kind, so that everybody isn't totally happy with the system.
Not at all. It's inevitable that there would be some lineups, and there are. I think the waiting in the halls is as much a product of the way we pay doctors as the lack of beds, because we have as many as the United States.
You have as many beds, or
it really depends on the part of the United States, because
sure.
there's terrific variation throughout the United States. But we have reduced our hospital supply quite a lot, and have obliged lengths of stay to be shortened, which has also happened in many of the insurance arrangements in the United States.
Does that compare in any way to the government's intervention in the United States with the Diagnostic Review Group, that they have taken a certain number of surgical procedures and said recuperation from this should take 8 days or 7 days or 2 days or whatever? Do you do that in Canada as well?
No, we don't, because we leave the management of a hospital very much alone, and if it chooses through its medical staff to do high volumes of outpatient surgery and control its discharge procedures well, and is particularly interested in the prioritizing of patients so that it's the ones who need things the most to get them first, then I think that in those communities you hear far fewer of the complaints you get from Montreal than you hear from Montreal. I don't hear those in Ottawa, and they have as many beds as we have.
What is the relationship between the national government and provincial governments? Who pays what kind of share? Does the province pay the doctors and the national government pay the hospitals, or how does that work, Dr. Sutherland?
The federal government, in its original carrot to the provinces, saying we would like to have a national health system or health insurance system, and we will encourage you to do that, promised to pay approximately half. And although there's lots of arguments about whether they pay it, it would probably still be in the range of 40 to 60%, with the difference being that poorer provinces have always had a higher percentage paid. The federal government doesn't give money specifically for doctors or for hospitals. It just gives tax points and gives straight grants, and it's up to the provinces to decide how they distribute that between hospitals, physicians, home care programs, public health, long-term care, and things like that.
And the government's involvement, I suspect, as far as monies to a specific province, are based upon the demographics, the numbers of population in that province. Is that the way they work it out?
All those factors are taken into account.
Now, I read in the paper this morning a story about your appearance here in Burlington last night, that the healthcare system in Canada costs half of what it costs in the United States. Is that true?
Well, I think that it depends how you count that. I think I said 50% more, which is it's only a third if you're going down. So that it's probably two-thirds of as expensive per person in Canada. But there are three variables in it. There's the gross national product. Ours is at 8.5, and yours is at 11. There is the difference in the value of our dollar, which you can ignore, or if you count makes a lot of difference.
Yes.
And there is the size of your gross national product. In other words, yours is bigger per capita than ours, so when yours is 11% of a bigger number, it's really a lot more than 8.5 to 11. But the safe number that people talk about the most is the 8.5 to 11, which says that on a national level, we have managed to finance a pretty comprehensive range of services, mental health, physical health, home care, everything, at a total national cost significantly lower in terms of national wealth than the United States has been able to do it.
When you talk about that kind of medicine immediately in the United States, you'd hear somebody say socialized medicine. You'd hear people say, hey, that sounds like the communist way of doing things. How do you react to that, Dr. Sutherland?
There's no doubt that Canadians historically have been much more willing to let governments do things than Americans have. And when you develop your system, which I'm sure you will, it will take into account that cultural concern about governments doing too many things. I don't think it's communistic. It's widely supported. All parties support it. It's all over the world, so that it's not limited to left-leaning countries.
Are we the only country that has a health system like we do, Dr. Sutherland?
I think South Africa is pretty much like yours.
Mm-hmm. Do you think it would be possible to get a bigger bang for our buck with the kind of system that the Canadians have if we had that in the United States?
Yes, I do, but I still don't think you should completely copy our system.
Why not?
Well, you have a marvelous, typically American innovation called the Health Maintenance Organization, and also a series of related kinds of terms, which has brought competition back into the health marketplace. And I would love to see you figure out some way to utilize that innovative approach, which I think is even more cost-controlling and quality-protecting than what we do. I'd love to see you build that into the idea of universality.
I think that, for example, one of the men who was intimately involved with that was Lee Iacocca at Chrysler, who took a look at how much of the cost of an automobile went in health care or health care benefits to Chrysler employees, came up with the HMO, whereby if you practice good health, you save some dough. Is that the way it works?
Well, I think he's taking credit for something which he really shouldn't. What he did was he looked around and he found that there were 5 or 6 million Americans getting cared for that way under the old Kaiser programs and HIP in New York and a number of others, and said that has proven itself to be 40% approximately cheaper than the other approach. Why doesn't Business America get behind that particular model? And they did, and that's why it's growing.
So what you're suggesting then is that perhaps we in the United States come up with a combination government HMO type of, or private vis-a-vis public health care system.
The reason you need the government involved is because people move around, they change jobs. HMOs tend to be geographically based. They tend to be limited sometimes to specific kinds of workers or kinds of people. And if you want universality, I'm not sure you want it, but if you do want everybody to get a reasonable level of health care when it's needed, then you do need to have some kind of arbitrator who can represent all parts of the society. It doesn't have to be quite as dominant as government is in Canada, but I don't see how you can have an umbrella kind of system in which there is a major referee that handles big business, big labor, consumer groups, the providers, hospitals, doctors, etc., states in competition with states, perhaps certainly HMOs in competition with HMOs. Somebody has to regulate this extremely central social service industry.
We, speaking of the government involvement, we do have the Medicare system, Medicare and Medicare B, that automatically goes into effect at the age of 65 in the United States, but of recent vintage, we find that there is more of an onus placed upon the person who is 65 to pay part of this cost himself. For example, I was listening to a Social Security representative yesterday saying, well, if you're over 65, you're responsible for the first day's hospital, which may be $500 and some odd, and you're only allowed so many days in the hospital, and after that, and you have a deductible on top of all kinds of situations where older Americans are now being forced to expend more for their own health care when they figure they ought to be getting something for nothing. The Medicare B is now $17.90, and it's going to almost $25 the 1st of January, and people who are trying to live on Social Security can't make ends meet. If the government can't pay for that, how in heaven's name are they going to pay for everybody in America?
Well, that's the common proposition that's made, but I think that if you decide what your objectives are, you can decide that it's cheaper for the government to pay more. Because two things actually happened in Canada. By the way, we went through the same lessons that you're going through. Just went through them 30 years ago. If you start to pay bills without having real negotiating clout with the people who submit the bills, then the volume of the bills is absolutely endless.
What you're saying is that the people, the providers, are going to charge as much as the traffic will bear.
And they will provide not just what the traffic will bear, but they will bill for it at any level they please. I mean, they will provide all the care they can, and they set the prices. That's where your DRGs, your disease-related groups, started to be seen as a device to control costs. And they are at the individual level. They work for an insurance company, but they don't help a society. And I think that we have a device in which governments negotiate with hospitals for their total budget. Governments negotiate with doctors for their rates of fees. And through these devices, we have in fact maintained the same pattern and package of services that you have from the same providers that you have, who operate in the same way you do have. The doctors are basically fee-for-service, the hospitals are independent entities. But because there is a major negotiation process, the costs are immensely lower.
And you're saying that doctors are limited. Is there a cap on how much a doctor can earn?
In Quebec there is, not in any other province. That's a pretty generous cap, but a variety of provinces have talked about how you limit costs. Capping is one of the devices that has been talked about. Other provinces are limiting where physicians can open an office, because if they already have too many in the urban centers, they'll move them out to the suburbs or out to the rural areas. And across the country, provinces are beginning to reduce the number of medical students, which is perhaps the most satisfactory way of controlling our doctor costs.
That sounds like an end of the free enterprise system.
Well, there is no doubt that when government becomes deeply involved in something, there is a major intrusion into something else. Power only is shared amongst so many people, and if somebody takes more, somebody loses it. And as I said earlier, Canadians are less concerned about governments being in a major way involved in transportation and in health and in education than the Americans are, and I think that's a cultural difference.
How do doctors feel about this?
Doctors, depends on the question you ask them. If you ask them, and of course many polls have asked them, do you want to get rid of the health insurance system? They all say no. All 90% of them will say no.
Because that's a guaranteed income.
Absolutely. If you ask whether they like the extent to which the government tells them how much they'll get paid, well, then their no is equally resounding. They would like to get paid a lot more. And I think that's a fairly normal human response, because almost any worker group, if you ask them whether they're getting all the money they'd like to have, says no.
Does that reduce the incentive to practice good medicine? In other words, does the doctor, is he less inclined to exert the best he can do because of the fact that no matter how well he does, he can only make so much money?
Well, I think there are an awful lot of motivators in the world besides money. And remember, our doctors are still by far the highest income group in Canada in terms of occupations.
How much do they make?
Well, they make about 4 times the average worker wage, and that's been stable since about 1945 when we started keeping records, so the ratios have stayed about the same. The average GP in Ontario, it still depends on whose figures you read, but it will be somewhere between $90,000 and $120,000 a year that they will make working full time.
That's Canadian dollars.
Canadian dollars. And specialists will vary from 160 to 225,000 perhaps by specialty. Our specialties differences are not as great as yours, because another thing that governments have done is kept pressuring to rearrange their payment systems so that certain kinds of physicians don't universally emerge as making $400,000 and somebody else makes $110,000.
Would a doctor such as yourself, you practice as a general practitioner in a rural part of Canada, Alberta, Saskatchewan, would you make considerably less than a high-powered surgeon in Montreal?
That would, yes, but that would, how much you make really is better compared within your class. As a rural GP, I made a lot less than most people too, because I don't think that money is the only motivator, and I don't think it's necessary to be so obsessed with your income that it ruins your capacity to enjoy an extremely lovely profession.
But you may be unique.
No, I'm not.
You're not?
No.
Lots of doctors feel that way.
Well, I think the number is slowly going down, but maybe that's also a reflection of society, that people are, in fact, a little less interested in their work than they used to be.
Do doctors rail at being told where they can practice? In other words, you've
Yes,
indicated...
they do.
Yeah.
That's being done only in British Columbia, but it's really a new point of contention.
Yeah, it seemed to me that I saw Barbara Fromm of CBC conducting a forum, and it was a violent confrontation. I'm not sure whether it was in BC or not, but wherever it was a violent forum of doctors and health providers who were really up in arms about how they were being treated by either the province or the national government.
That was the extra billing issue.
What do you mean by extra billing?
That was the question of whether a physician, having delivered an insured service to an insured person, was entitled to also bill the person for some more.
Okay.
And about 11% of the doctors in Ontario were doing that. It has now been declared illegal, or at least it's not really illegal in a criminal sense, but you can't do it anymore.
I understand that's the way the system, the socialized system in England works, that doctors exert part of their time for the national health insurance and then go home and treat wealthy patients in the afternoon or evening hours at a remarkably higher cost, so you have a two-tier health system in England. Is that correct, Doctor?
I think almost everybody but Canada has a two-tier system, and I think that logically we ought to. Not quite the way you describe it, but one of the strange features of the Canadian system is that the government-financed hospitals and physicians are really the only place you can get care. And there's probably 20 doctors in all of Canada that have opted not to be involved in this system at all, and you go to them and you pay all your bill and you don't get any money back. Because in Britain you can go and get your level of care that is available in the national system for free, or you can go to the private system and then get anything you want and you pay all of it and don't get any money back. I'm saying we don't have that second tier in Canada. I think it's a little inconsistent when you can do that in education and you can do it in recreation and you can do it in virtually all the fields in which government does operate in Canada.
Canada is people think about Canada as a very big country, and it is, but they don't realize how small the population is compared to the United States. How many people are there in Canada?
About 25.5 million.
Yeah.
10% we usually say.
And my father who was a retired postmaster, used to say to me that the New York City post office does more business than all of Canada put together on a day or weekly, yearly or whatever basis. This was some years ago, but I guess that's probably a fairly decent criteria. How much does the healthcare system cost in Canada?
Costs about $1,400 to $1,500 per person for 25 million people. If your math is real fast, you can
It isn't.
put a figure on that.
$1,400 to $1,500 per person.
Yeah, that's not government expenditures. That's all the expenditures on health care, and that's the figure that goes into that 8.5% of gross national product. That's not government expenditures. That's just everything that anybody spends on health care.
So that 8 to 9% of the GNP in Canada is what health care costs.
Yes.
I have to plead ignorance in this. Do you have any idea what the percentage of health care costs in the United States are compared to GNP?
Just about 11 now.
Why does it cost us so much? Because
Well, it
people
costs you
charge
so much
what the...
because the prices aren't controlled. Because there isn't a rationalization of the system, or whatever jargon you want to use. There is no overall planning. The thing that came after, after government said, we want to get money, we want to take money away so that it doesn't prevent people from getting a decent level of care. They started just saying that. Very shortly they discovered the costs were rising terribly. They said, we now have to become planners. We have to become concerned about how many institutions we have, about what kinds of services they give, about how much duplication there is. Because if we don't control hospitals and doctors, we won't be able to expand in the areas which have been the highest priority in Canada for the last decade, and that's long-term care and home care. And we have pretty major innovative programs now which will allow pretty severely disabled people to live at home, which is usually where they prefer to be.
So you fund home health care.
Oh, all the home care programs are free to patients.
So that, do you then find that you have less of a system of of some kind of health facility between the hospital and the nursing home, or that you have less people in nursing homes and more people who are at home and cared for by visiting nurses, or something that approximates that?
We certainly have a lot more being cared for at home. In Ottawa, on any given day, there's about 3,000 patients in our home care program. We are very slowly reducing our number of elderly that are in institutions. We have a lot of them there.
Why is that? Because it's cheaper, or because it's better to have them at home?
I think it's mostly, well, why they're at home is because it's better. I think it also is cheaper, but we don't cost things well enough to be certain of that. But it certainly is better. It allows families to continue to be involved in care. It allows people to spend their disposable income in the ways they wish.
Mm-hmm.
It is hopefully also cheaper. Certainly, there are too many people in Canada who go to institutions because it's the cultural thing to do. Families think that's where the care is, and doctors tell their patients this time they went to a nursing home, when in fact what they really ought to be doing is getting more support at home.
Dr. Sutherland, how does Canada address what seems to me it might be a problem in the United States, that we have a rather critical shortage of nurses here in the United States now? And they say essentially because they don't get paid enough. And they relate their problem to maybe a teacher and the range of teacher salaries. They relate themselves to something else, and they say, well, I have a skill, I worked hard to obtain it, I spent a lot of money for it, and I should be compensated better than I am. When the healthcare system started out in Canada, do you find that you had a lot of that type of thing? Is there animosity or anger or whatever toward people who, because of the fact that the government doesn't control what they make, can make more money? In other words, should you have a kind of a structure all along the line as to how much anybody can make? Can I ask you to come up just a little bit closer to the mic? Yeah.
Well, I don't know. That would be a major extension into government control, which I think the average Canadian would have some trouble with yet. There are groups of people who make what they please, and there is no doubt that physicians will say, but look what my friend the stockbroker makes.
Yes.
You don't control him. Well, socially, we have not declared stockbroking to be an essential service, and if it were, then government would, I expect, control it, the same as we govern police security forces and we govern educational standards and personnel. And society tends to only write rules about those groups that they have selected as being crucial to them.
Can people strike?
Yes. Well, that's quite variable
doctors
from
or
province
nurses?
to province. Doctors can strike whenever they like. Nurses, it varies from province to province, and with other health workers, it's also variable by province.
But they strike against the government rather than a specific hospital or specific employer, correct?
Still varies by
tougher.
province, because in some provinces they do provincial negotiation.
Has that happened?
Yes, it's happened in Alberta, and nurses struck twice in the last 10 years.
What happened?
Well,
Did they get what they wanted?
They go through the process of reaching some compromise between what they wanted and what government is prepared to give, and then the strike is settled. Sometimes they've been voted back to work, I believe.
Ordered?
Yeah, ordered back.
As in the case of the flight not flight attendants, but
right now.
Yeah, that the president fired a lot of the traffic controllers
in the
United States.
Yeah. Well, that's more vigorous than we tend to be. We tend to legislate people back to work. Just tell them they've got to go back to work, or else they'll be penalized in some way for not doing that. And that has not been done with physicians as yet, and I would think it's probably not likely.
Dr. Sutherland, did you lose a lot of physicians? Did a lot of them come to the United States when this healthcare scheme went into effect, or during the intervening years, or now that this cap struggle is taking place?
Quebec has lost more physicians than most provinces, but a number of people have studied that and believe that the pattern of transfer is about the same all the time. In other words, we have always had the typical international brain drains in the United States. Two kinds of people go to the United States: the very highly qualified researchers and teachers who you want because they are so good and we wish we could keep them, and then a lot of physicians who believe there's greener pastures, less controls, more money, a social system they like better, and they move for those reasons, and they've always done that, and every one of our professional groups does that, including nurses.
to the photo lounge this Halloween to get an archival photograph of my wild Halloween costume. I know I'll see you there too.
Drop down with Felix at the photo lounge. 8 years of photographing the best in Halloween fantasy. Winooski style, man, cool. The notion of constructing a bike path along the city's waterfront has been an idea that surfaced a number of years ago. It seems like this notion was on its way to reality in the early 1980s. This was around the same time that the Community and Economic Development Office was created. At that time, with a bit of controversy, there was a discussion as to who in fact should be responsible for the planning and construction of the bike path. After some controversy, the Board of Aldermen agreed to delegate that responsibility to the Community and Economic Development Office. One segment of the bike path, the segment from the mouth of the river to Star Farm Road, was constructed with Community Development Block Grant Funds. The segment from the middle segment was constructed in prior years with Parks and Recreation monies, I believe, in the late 1970s. Most recently, first with a $750,000 bond issue, most recently with the approval of a $2.9 million bond issue, we have been able to proceed with the planning and implementation of the waterfront bike path. We have had for the past year this so-called missing link of the bike path, which was that segment from the Barge Canal to the Lakeside neighborhood, and I'm very pleased to say that construction on that segment will be underway within the next week or two. Bids were opened last Friday for that segment, and it will be substantially completed over the winter and paved in the springtime, so the entire lakefront bike path will be complete in the spring of next year. I think it's a really exciting asset. I get out there on a very regular basis myself, and there are just hundreds, if not thousands, of people that are taking advantage of this amenity, walkers, joggers, and bikers. Not only is it a recreational opportunity, but many people are also using the bike path to get to and from work, so it's also providing an alternative form of transportation. But we're not going to stop at the lakefront bike path. We're going to continue our efforts to construct a bike path which will ultimately loop the entire city. We've made substantial progress in planning for a path from Shelburne Road adjacent to the South Meadow project and along the Southern Connector, and ultimately link Oak Ledge Park, and we're hopeful that this segment will be constructed in the spring as well. We're also undertaking planning to connect the bike path from the mouth of the Winooski River to the pathway adjacent to the Northern Connector. So by next summer, optimistically, one could travel from Shelburne Road to the Intervale on bicycle. So I think it's a very exciting development that is taking place within the city. When one hears the word of development, you frequently think of skyscrapers and retail malls, but in development, at least from the perspective of our office, in many cases it's development for public use and enjoyment, and it's development that will serve a broad spectrum of Burlington's population. What's your name? What do you